Thank you very much, Dr. Khanna, and I would like to thank you for giving me an opportunity to present my work on penile artery Doppler study. First of all, you should say this prevalence of the erectile dysfunction, it increases with age. Within an age group of 18 to 29, it's only 7%, and the age group of 60 to 69% becomes 34%, and at the age group of 70 to 80% becomes 53%. Now, how do you have the erection hardness score? That is very important. You have to see both the Doppler study as well as when you have injected the stimulant, and we use either the papaverine or we use a prostaglandin. In that case, we look for hardness. So this erection hardness score, or EHS, 0 is flaccid, grade 1 is tumescence without hardness, grade 2 is tumescence with non-penetrable hardness, grade 3 is tumescence with penetrable hardness, and grade 4 is tumescence with complete hardness. Now, amongst the causes of erectile dysfunction, we of course have a psychological causes, which consist of either a psychological trauma or a relationship problem with a partner, or a dissatisfaction, family and social pressures, depression. And then you have some organic causes, which are very important. And we have the hormonal causes where the testosterone levels and the gonadotropins are low. Then we have the vascular causes, which can be either endothelial dysfunction or atherosclerosis, or it can be venous leak. And then it can be associated with chronic medical conditions, and it can be associated with the muscular asthenia, that is the myogenic etiology. Now, why do you want to do a penile artery Doppler study? It helps to rule out any psychological causes, number one, and it helps to rule in many vascular or the muscular causes. The endothelial dysfunction, for example, Peyronie's disease, which is a muscular etiology, arterial stenosis, and a venous leakage. Now, this is the anatomical background. We have these cavernosal muscles, which are situated on the dorsolateral aspect, right and the left cavernosa, along with the cavernosal arteries. And we have the dorsal artery of the penis. And on the ventral aspect, we have the spongiosa. Now, when we are looking at that how this erectile response occurs, that you have actually the guanylyl triphosphate converted into cyclic GMP using the enzyme guanylyl cyclase, but here the nitric oxide is very important. This nitric oxide helps to catalyze this also, and the nitric oxide itself is a potent vasodilator. So dilates the blood vessels and it causes erection. And you can see that how this erection occurs. These vessels arteries become engorged, and the veins in these cavernosal spaces, they get constricted. So the arteries get dilated and engorged, and the veins get constricted. So you have detumescence, where the arteries are not engorged and the veins are of good size. And when there is a tumescence, then the arteries are engorged and the veins are constricted. So this is how you do a penile artery Doppler study. You place the probe on the ventral aspect of the penis, and the penis is placed on the abdomen, and you use a linear probe of the frequency between 7.5 and 11 megahertz. That is the frequency that is used. And you see the spongiosum on top, and you see the right and the left cavernosa, and you see the cavernosal arteries. Now this is the longitudinal scan, and you can see the cavernosal arteries here. And this again is the right cavernosal arteries. You can see the moving clips. Again, you can see the cavernosal arteries. And this is the normal penile artery Doppler spectral waveform. This is the Doppler spectral waveform. In the basal condition, the peak velocity, it varies between 5 centimeters per second to 12 centimeters per second. And you have generally a high resistance form where the diastolic flow is much less. You have mainly the systolic velocity. And to some extent, there is a diastolic velocity. It could be there. So what is the PDS protocol? The patient is appropriately counseled. The procedure is explained and an informed consent is taken. It is preferable to keep the patient fasting for about 4 to 6 hours prior to the test. A linear probe, as I said, of 7 to 11 preferably, not 5, frequency is used for this test. A low Nyquist limit that is kept is at about 10 to 15 centimeters per second, and a low filter setting of 50 hertz and a low PRF or 2 to 4 kilohertz is used for this procedure. With the patient in the supine position, his penis is positioned so as to lie on his abdomen. At the basal region near the proximal 1/3 of the penile shaft, the cavernosal artery is identified, and in the longitudinal plane, a color Doppler study is performed. The diameter and the peak flow velocity of the cavernosal artery is then measured and documented during the flaccid stage. And what are the cavernosal stimulants that we use? We use either the papaverine, 30 milligram to 60 milligram, the phentolamine, the prostaglandin 1, and what we use commonly sometimes is alprastodil, 10 microgram to 30 microgram, and we also use chloropromazine. But most of the time we use either papaverine or we use alprastodil, and usually and occasionally we can use a triplex combination of a papaverine, phentolamine, and chloropromazine. What are the normal parameters? The diameter of the cavernosal artery varies normally from 0.6 to 1 millimeter in its basal flaccid state of penis. During the vasoactive stimulation or the sexual arousal, the diameter increases by 75%. The basal peak velocity of the cavernosal artery is in the range, generally in the range of about 5 to 12 centimeters per second in the flaccid state, and increases to about 40 centimeters per second or more during the arousal in the erect penis or after a cavernosal stimulant. The normal pattern of the peak velocity shows an acceleration time of less than 100 milliseconds with little or no diastolic flow after the first 10 minutes of injection of the cavernosal stimulant. So this you can see in the basal state, the peak flow velocity is slightly on the high side, 14.3 centimeters per second, but that is also quite normal. And then by the 10th minute, you're getting this peak velocity of about 38.9 centimeters, close to 40 centimeters per second. So this is almost like a normal response. The test is read as abnormal if the peak velocity after injection of a cavernosal stimulant is less than 25 centimeters per second, and this codes for the arteriogenic etiology. That is, usually it is atherosclerosis for erectile dysfunction with a 92% accuracy. A peak systolic velocity after a cavernosal stimulant is about 35 centimeters per second is considered normal. An end diastolic antegrade velocity, EDV we call it, of 5 centimeters per second is normal. A value of above 10 centimeters per second is certainly abnormal. And what is resistance index? Is the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. The maximum velocity, this maximum value can be Ri of 1.0 because the EDV can be 0. In that way, this ratio will be 1. And after a pharmaco stimulation, an Ri of less than 0.75 is associated with venous leak in 95% of patients. Ri of more than 0.9 is consistent with a normal response, and this cavernosal stimulant in about 90% of such patients. So therefore, you have a peak systolic velocity if it is less than 25 centimeters per second, whatever may be the Ri value, the interpretation is atherosclerosis or an arterial block. If it is between 25 to 35 centimeters per second, that is somewhat reduced, and the erectile grade is 3 or less, then that is endothelial dysfunction. If this velocity, end diastolic velocity, is less than 5 and the peak systolic velocity is more than 5, and the EHS grade is 3 or 4, that is normal. If the peak systolic velocity is more than 35, but the end diastolic velocity is less than 5, but the EHS is less than 3, then we call it a myogenic, which means a normal penile Doppler study with an impaired erectile response. A normal penile artery Doppler study, and with an impaired erectile response, that is EHS or an erectile hardness score of less than 3, we call it myogenic. And a peak systolic velocity of more than 35 centimeters per second, end diastolic velocity of more than 10, Ri velocity of less than 0.75, this is definitely a venous leak. Now this is a 45-year-old male with erectile dysfunction. He has got a basal peak flow velocity which is normal of 8.2 centimeters per second. After 20 minutes, it becomes 14.6 centimeters per second. So it's much less than 25 centimeters per second. And you also see a damped pattern. You also see that the acceleration time is much more than 100 milliseconds. So this is the damped pattern, and this indicates that we are dealing with an arteriogenic pathology, either atherosclerosis or a proximal arterial block. The block can be either at the abdominal aorta, it can be at the common iliac artery, can be at the internal iliac artery or the branch of the internal iliac artery, or it can be at the pudendal artery. Now this is this patient, a peak systolic velocity of 14.6 that we just mentioned, EHS of less than 3, indicative of atherosclerotic disease. He has a critical narrowing of the left common iliac ostium. You can see the left common iliac ostium, a turbulent flow, a mosaic pattern of flow. And when you do the spectral Doppler, you see an extremely high velocity. So in the right-hand panel, you're seeing an extremely high velocity. So this indicates that this is atherosclerotic disease. Now you can see another example, a 60-year-old male. He had a peak systolic velocity of only 23.1, so less than 25, of 7.67, Ri of 0.67. So in this case, the Ri is not important because he has not attained the peak velocity. So our diagnosis is atherosclerosis and not venous leak, even though his Ri values are low, but that is because of the incomplete filling of the cavernosa, incomplete cavernosal filling. Another patient, a 40-year-old male, a peak systolic velocity of 53.7. He has got a biphasic response. So he has got a normal peak systolic velocity. His erectile hardness score is 2, which means an incomplete erectile response. So this is a myogenic etiology. And we also call it a cavernosal muscle asthenia. This can be a Peyronie's disease or a non-Peyronie's disease. A myogenic etiology can be a Peyronie's disease when there is a curvature of the penis during the erectile phase, or it can be a non-Peyronie, which we also call a cavernosal muscle asthenia. And there we see plaques. You can see plaques in the cavernosa, these white plaques. These are suggestive of a cavernosal muscle asthenia, whether it is a Peyronie's or a non-Peyronie's. Another patient, a 55-year-old male, he has got an EHS of 3. He has got a relatively less peak velocity. This peak velocity is somewhere around 29 to 30 centimeters per second. It is more than 25, but less than 35. So this is endothelial dysfunction, and this is one of the most common cause of erectile dysfunction is actually endothelial dysfunction. The endothelial lining of the vascular bed, it produces less amount of nitric oxide in patients with endothelial dysfunction. And in these patients, the nitric oxide molecules is very short-lived. The supply of nitric oxide into the arterial muscle is decreased, causing less dilatation. There is decreased inflow into the cavernosa, leading to erectile dysfunction. And these patients respond to these medications like sildenafil or tadalafil. These are the medications which are the PDE5 inhibitors. These are the ones that are used, and these patients are the ones that are most responsive. The other group of the etiologies are not that responsive to the PDE5 inhibitors. We have another patient with a 32-year-old male, peak systolic velocity 55.7 and diastolic velocity of 13.7 centimeters per second, RA velocity of 0.7, erectile hardness score of less than 3. But you can see that the RA values are low and the peak systolic velocity is quite good. So this means that this is a venous leak. So this is a typical anatomical venous leak, this sort of a pattern when you see. So in conclusion, the penile artery Doppler study is important to define the cause of the erectile dysfunction. It helps in therapeutic guidance and monitoring the response. Endothelial dysfunction is an important cause of erectile dysfunction amongst the young ones. And ideally speaking, the vasoactive medication should be prescribed only after a penile Doppler study and not just on a clinical basis or just as a therapeutic trial. It is better to have a baseline penile artery Doppler study before you put the patients on the vasoactive medication or plan any other form of therapy. Thank you. Thank you, Dr. Khanna, for giving me an opportunity, and thank you to the audience for a patient hearing.
Thank you very much, Dr. Kapur. We all had many questions. I can see them on the chat box. I can see them on the other groups which we have got. But we have to move to the next session because we are quite late. Let's go. Thank you all very much. Thank you, Amri. Thank you, Dr. Kapur. Thank you, Virender. And thank you, Dr. Rakesh Gupta and the panelists. So the next session is a very important session on cardiovascular update.